everybody. Today's talk will be about the effect of contraceptive products and can they really induce infertility and bring patients to problems resulting the need for ART later. So the issue is that the fear of adverse effects of subsequent fertility following reversible contraceptive is a big problem all over the world, which makes women stop using contraceptive or not start them at all, and this leads to abortions and many other complications that can alter the future fertility. Any fertility delay or impairment following the stopping of contraceptive method may be associated with poor use and satisfaction in young women mainly. And the misconception is very high. We all know those young women approaching us and asking us what are the contraceptive pills are going to do to their future fertility. The negative association between age and fecundity is generally well accepted and is also related to reduced coital frequency, decline in fertility, and increased risk of prevalence of underlying gynecological diseases. We also know that smoking and obesity and exposure to a number of environmental toxins, like we see, for example, in fish and other solvents used, can be associated with impaired fertility. Studies assessing pregnancy rates or the time that follows between stopping contraception may be influenced by a number of underlying factors specific to the certain population that we are looking at. The range, what is really the range of the normal pregnancy rate? So the range of 1 year pregnancy reported in retrospective studies of women wishing to get pregnant after stopping barrier methods is somewhere between 85 to 94%, which is very high. And of course, this is what we expect to see in the normal population. But as we said, chances of conception vary by age. So the odds of getting pregnant in a given month, and the number are different in many articles, are different in every age of the woman. So in the early 20s, it would be up to 25%. In the late 20s and early 30s, it would be about 15%. And in the late 30s, it would be 10% for every month. We can look at it at a different way. The chances of conception by age, by the average of months it will take a woman to get pregnant. So in the early 20s, it will be about 4 to 5 months. In the late 20s, it will be about 5 to 7 months. Goes up to 7 to 10 months in the early 30s, and in the late 70s, it can take up to a year. Number of women who achieve pregnancy within the first year by age can be 94% in the early 20s, later in the late 20s and early 30s, 70 to 85%, and in late 30s, 65 to 70%. So you see, we can look at fertility from many different angles. And in another article, you can see the numbers are not exactly the same, but also we see the decline with age, which is obvious. And the numbers here are a little bit different because they will not always be the same because it depends which population we are looking at. So what about combined oral contraceptive and fertility? In the 1960s, following discontinuation of combined oral contraceptives, the initial reports suggested an anovulation syndrome and infertility in some women who previously had regular menses. It may be attributed to transient persistence of ovarian suppression secondary to inhibition of gonadotropin secretion, and clinicians feared that long-term ovulation suppression with combined oral contraceptive could lead to a state of prolonged ovulatory suppression and delay the returning to normal ovulation, resulting in some women remaining amenorrheic for more than 1 year. And from there, we had this habit, which now, of course, is abandoned, that we used to tell women to take oral contraceptive for 6 months and then stop them for 1 or 2 months, which today we know that has no logic at all, and many of them, first of all, get pregnant, and then stopping and renewing oral contraceptive increase VTE risk, because you know that VTE risk with oral contraceptive is mainly when you start them in the first year. So when a woman stops oral contraceptive and starts them again, actually she exposes herself to the same risk. So this habit of stopping oral contraceptive and renewing them afterwards is not logical. Many studies on oral contraceptive have found a short-term delay in return, but no study has suggested long-term or permanent impairment. This is very important. The Oxford Family Planning Association study, which was published first in 1978 and included more than 76 women, which 56% of them used combined oral contraceptive, reported significant delay in fertility of up to 42 months for nulliparous women and up to 30 months for multiparous women after the discontinuation. They continued their report, and in 1986, they reported that 48 months after cessation of contraception, almost 18% of combined oral contraceptive users were undelivered versus 11% of those using a different contraceptive method. But here, once we have a problem, what do you look at? Do you look if they get pregnant, or do you look at the delivery? Here they looked at delivery rates, so they did not include any women who did abortions or miscarriages in the meantime. In another controversial observational cohort study, women who used a combined oral contraceptive were categorized into two groups, because those studies conducted in the 70s were conducted on women using high doses of estrogen. So here they tried to differ them. They took one part of women who used less than 50 micrograms and women who used more than 50 micrograms. And there was a greater delay for those who discontinued oral contraception in doses of 50 micrograms or more estrogen, 4.8 cycles, than those on lower dose, 4.01 cycles. Today we use, of course, less than the half of those dosages. In this article, they differentiated combined oral contraceptive use by the same dosage group while looking at the association with primary infertility. And infertile women were not more likely to have taken oral contraceptive with high estrogen doses than control. Combined oral contraceptive use in this study was associated with a lower risk of primary infertility, which means completely the contrary than what was suggested before. What about the duration of use? Is there any limitation to the duration of use of oral contraceptive, and does this have any influence on the fertility? So there have been mixed results about those issues, and also the Oxford Family Planning Association study and the nested case control from the Nurses' Health study found no association between increased duration and use of fertility. Two other studies found the duration to use to be significant. In one study, 2,841 women in the UK completed questionnaires measuring by time to pregnancy. They found time to pregnancy to be twofold longer for long-term users, more than 2 years, than users of condoms. And the time to pregnancy for short-term was similar, 4.8 months. These effects were found to be greater for older women, obese women, and women with menstrual disturbances. Of course, like we said before, we have got problems of fecundity in those groups of women. Although age may have become a larger issue, it should have affected both groups. And so the age, they think, was not a big problem in this study. Controversially, in another study, Farrow and his colleagues found that prolonged use of more than 5 years was exactly the opposite, associated with increased proportion on conception within 1 year. These studies included combined oral contraceptive users who started the medication for contraception and cycle control, which could imply fertility issue. We must remember that a lot of those young girls that we put them on contraceptives at the age of 15, because they have got acne, because they have got menstrual disturbances, they have got already fertility problems, and when they take it for many years, of course, when they stop it, those problems reappear. Many of those studies were of current pregnancies. Therefore, those who failed to conceive were excluded. What about endometrial sickness? This was one study published by Casper and his friends 1 year ago, where they looked at 137 patients with a history of oral contraceptive use, and endometrial thickness was measured by transvaginal sonography on day 10 on those patients and divided between 7 millimeters less or more. Long-term combined oral contraceptive of 5 years or more, they showed can potentially affect optimal endometrial growth, leading to a higher cancellation rate and longer stimulation in frozen embryo transfer cycles. But of course, this is a very, very special group of patients which had already fertility problems. It's also a small group of patients of 137 patients. Out of those, 40 and something were only those with long use. So this is not seen in most of the other articles. This is the latest article produced about this subject this year, where data was derived from prospective cohort study which enrolled 3,727 Danish women who were pregnancy planners aged 18 to 40 and when followed up to conception or for 12 months, whichever came first. 97% of them had ever used oral contraceptive. The median age of use was 70 and the median duration of use was 7 years. Compared with barrier methods, the use of combined oral contraceptive was associated with a short-term delay of fertility of 1 or 2 months. Longer-term combined oral contraceptive was associated with a higher fecundability, exactly the opposite of what we feared, compared with oral contraceptive who were used for less than 2 years. The chances were 0.98 for 2-3 years, 116 for 4, 110 for 6-7, and you see all the numbers, even after 12 years, the rate of infertility was a little bit higher, but of course here we are dealing with much older women. So actually, it is agreed that most combined oral contraceptive users are likely to experience a transient delay in conception compared with those discontinuing barrier methods. What about prolonged regimens? Today, you know, we have the tendency to use prolonged regimens of giving women 90 days of oral contraceptive and having a period once every 3 months. We've got dedicated products for this. I don't know if in India you have them, the Seasonic and the Seasonel. They are products produced in the States which already contain boxes of 90 pills packed together. But we do it also with normal contraceptive. Here we have a study where with 21, it's a small group, but we see that the pregnancy was 57% at 3 months, 81% at 12 months, and 86% at 13 months, with a median time of 4 months from discontinuation to conception. Another observational study of 187 women found a spontaneous pregnancy occurred in almost 99% of women within 90 days of discontinuation, which means that this type of regimen has no influence about future fertility. So what about this syndrome that the older doctors, we all learned about it, about the post-pill amenorrhea syndrome? Apparently, what it seems that although there are changes in the hypothalamic pituitary axis in terms of release of FSH and LH, resulting in anovulation in women stopping combined oral contraceptive, the evidence does not support a cause and effect phenomenon. Women who have stopped taking combined oral contraceptive should experience return to menstruation within maximum of 6 months after discontinuing the pill. And women who do not return, you cannot call them post-pill amenorrhea. You have to start investigating because probably those women have some underlying problem which is not related to the pill. But even though there are still doctors who fear this situation, and there are still doctors who take women after 8 or 10 or 11 months after stopping the pills and still telling them, yeah, it's because of the pill and don't do any investigation. So this is, I think, the right way to start dealing with it. This is a review published in Contraception 2 years ago, and in this review of the literature, they showed that actually the median time to pregnancy is about 2.5 to 3 cycles. On the right-hand side, you can see it. I don't have a pointer. So there is no apparent delay in conception after combined oral contraceptive. So the effect appears to be mixed. Some studies showing increase in 1 year of pregnancy rate with increasing age, although not always significantly so, and others showing no such decrease. Some studies suggesting that age-adjusted pregnancy rates were significantly higher in parous women and lower in the nulliparous women, and in others unaffected by parity or even significantly lower in parous women. But the numbers are always very small, and when you have so many articles dealing and one showing a little bit impairment and one showing less, so probably there is not much into it. In this same review, the studies assessed the effect of duration on contraceptive use, also suggested that pregnancy rate were not affected. One study only showed that current smokers had low pregnancy rate than non-smoker. The type of the progestin used in the pills had no major effects on pregnancy rates. What about the patch and the vaginal ring? Actually, at the moment, there are no current studies that can evaluate the return to fertilities after discontinuation of those products. But pharmacokinetic studies have shown that the plasma half-life of the norgestromin and the tenyl estradiol after patch removal is similar to the half-life after oral dosing. Trials with vaginal ring have shown that median time to ovulation was 17 to 19 days, suggesting also no delay in fertility after using the vaginal ring. What about medroxyprogesterone acetate? Medroxyprogesterone acetate is associated with prolonged amenorrhea and ovulation after the last injection, which is shown to cause delay in ovulation. It acts as a gonadotropin inhibitor and preventing follicular maturation and ovulation. Speculation on the mechanisms are many, but probably it is the suppression of the ovarian function. Others suggested that the drug is still stored in the fatty tissue and continues to be delivered even after the last injection for many months. This delay in return is likely attributable to the persistence of active drug metabolites in circulation rather than the lack of recovery of the hypothalamus, pituitary, or ovary after the drug elimination. And this is also very important. So actually, as we start to see, even though there is some delay, probably the only thing we should tell those women, don't stop those pills on January to get the injections, don't stop them on January to get pregnant on February, because there will be a delay, but it's not a reason not to use them. In 1974, an article showing a median time to conception was about 10 months, and 90% cumulative conception rate at 17 months. So it means that at 17 months, we return to the normal numbers that we know. Only 68% were pregnant by 12 months, but that increased to 83% by 15 months. In another study, the 12 months cumulative conception rate was 67.4. Mean time to pregnancy was threefold longer with depot medroxyprogesterone acetate than with condom use. The delay in return of fertility has been reported to be on the average 10 months or longer, especially in the same group of problematic patients who are older, obese, smoking, or with menstrual disturbances. As I said, many studies suggest that the duration of use of medroxyprogesterone acetate has no relation to the return of fertility. One study, however, showed 9.2 months after short-term and 17.2 months after long-term, which means that in this study, they did have a difference between short and long-term. No difference has been found between nulliparous and multiparous women. Although there have been no evidence of permanent sterilization being caused by the medroxyprogesterone acetate use, the return to fertility may take up to 2 years in some patients, in some women. And this is how you would see it compared to a non-hormonal contraceptive user. You see that the 50th percentile would be getting pregnant at about 10 months. I know that in India you stopped using medroxyprogesterone acetate as family planning a few years ago, if I'm not mistaken. What about implants? If we look at the United States, they have got only one single rod implant with progestin etonorgestrel. Within a week of the removal of the device, the serum concentration are in the essence were very, very low. One prospective study of the mechanism of action, which is the ovulation inhibition, of course, found a return to ovulation within 6 weeks of removal. Another small pilot study showed that after removal, 25 of 29 users returned to menstruate and 6 conceived within 3 months. On the basis of these few small studies, it appears that there is no long-term delay. One study, however, the 1-year pregnancy rate for past users of implant was unexpectedly wide. In other studies, between 37 to 85. Now, this 37 comes from one study which comes from Indonesian women who reported unusually low 1-year pregnancy rate, 37 and 48.8. Doesn't matter if they use Norplant or Implanon. Both were very, very low rates, which lasted for 2 years. Now, this does not come in line with all other articles that we have. So all the factors that might explain the low pregnancy rate were not discussed in this article. It is possible that there was underreporting of aborted pregnancies. Another explanation is that the motivation of those women to get pregnant was very low because they had a very low pregnancy rate of 2.3, which is low compared to what is seen in Indonesia normally. And considering the low pregnancy rate was seen in both implants and is not consistent with other reports, it is unlikely to be with any clinical important difference. What about intrauterine devices? The main 2 intrauterine devices used today in the world are the copper IUD in all different forms that it has, and the levonorgestrel releasing system. And they are very highly valued today, and most of the world, especially the Americans, are now pushing much and much more towards the use of IUDs. They initially became controversial because of reports associating them with the salpingitis and subsequent infertility. And this is the trauma which was caused in the United States by the Dalcon shield in the 70s, where they had septic abortion. But this was due to the string of the IUD, of this special IUD, which today is not used because today we use monofilament strings. So more recent studies, however, have shown low incidence of salpingitis among IUD users. But still, most doctors are still stuck with this notion of what happened 10 or 20, 30 years ago. So we are trying, as I said, now to change it, and long-acting reversible contraceptive, as the ECOG says, have few contraindications, and almost all women, including nulliparous women and adolescents even, are eligible for IUDs. This is something that comes from the States, which was unheard of, because don't forget that the United States had up to 5 years ago, they had 1% to 2% usage of IUD. Just today, they are starting to climb back. So what about tubal infertility among newly gravid women using IUD? Here in this article by Hubacher, who writes a lot about those things, 358 women with proven tubal occlusion and 553 women with other fertility problems, and 584 primigravid women were in this study. No link, very important, no link was found between the occlusion to the length of IUD use for the reason of its removal or the existence or non-existence of IUD-related gynecological problem. A direct link was found between positive chlamydia antibody titer and tubal occlusion. And this is logical because we all know that today what we consider the problem of PID in uses of IUDs is mainly limited to the first 20 days of use, the first 3 weeks of post-insertion. The length, the longer they use it, the less chances they have to have a PID. And this is due to an existent infection, usually in the Western world it's chlamydia, which is there at the day where the IUD is inserted and just pushed by the clinician inside the woman. That's why you see it in the first 20 days. So the overwhelming finding today is that there is no impairment of fertility caused by the use of IUD. In a recent published review of IUD use and the effect of fertility, randomized trials found up to 90% to 100% pregnancy rate, and a case series found 95% to 96% pregnancy rate by the end of the study. A study that evaluated both types of IUD, the IUD and the IUS, found the median time to conception was 3 months. It's exactly like barrier contraception with IUD users, with copper IUD users, and 4 months with the levonorgestrel IUS groups, with cumulative pregnancy rates of 91.1 for copper and 96.4 for the levonorgestrel IUS. The mean time to conception after IUD removal in different prospective cohort study was 5.4 months. So the majority of evidence support the duration of use of IUD has nothing to do with the return to fertility. Dole, in one article, however, found that long-term use in nulliparous women was associated with impaired fertility. Others, Hassan and Kilik, found the opposite result. Women with short-term had a longer time to pregnancy than women who were longer users, 5.8 and 3.8. So in any case, both those times are within normal limit, what we would expect. There are no difference in the return to fertility among women who had IUD removal secondary to desire of conception or secondary to complication. This is very important. So it doesn't matter if you took it out because they wanted to get pregnant or you took it out because they had bleeding, pelvic inflammatory disease, expulsion, or vaginal discharge. In any case, the pregnancy rate was the same. And once again, the ECOG states available evidence suggests that IUDs are more effective and have higher rate of satisfaction in nulliparous women compared with oral contraceptive. And these numbers are increasing in the States and in Europe. In Israel, for example, we do not manage to increase the usage of IUDs in nulliparous, and still we see those women getting 1 abortion, 2 abortions, and the doctor puts them back on the same oral contraceptives that they were using before and which they proved already that they failed to use, and they still put them on the same product because they've got this knowledge in the back of their minds that IUDs and nulliparity does not go together. And the woman is already sleeping in the OR while you do the abortion, so why don't you put her an IUD and you finish it? So if I would have to conclude about the effect of oral contraceptives and fertility, so you can see that if we look at median time to conception with oral contraceptive pills in between 3 to 6 months, with depomedroxyprogesterone 10 months, copper IUD and levonorgestrel IUS 3 to 4 months, vaginal ring with this variability due to this Indonesian study. If we want to look at it differently, the 1-year pregnancy rate, we can see that with barrier method it would be up to 94%. With oral contraception, the same numbers exactly. Copper IUD and levonorgestrel IUS, also the same range of numbers. Implants a little bit lower, and of course the depomedroxyprogesterone acetate stands on 68, which is the lowest one. So if I would have to conclude, I would say that most of reversible methods available today offer a prompt return to fertility after discontinuation, except the medroxyprogesterone acetate. None of the methods, including the depomedroxyprogesterone acetate, does not have a permanent sterilization effect. And underlying causes of female infertility like tubal disease, ovulatory dysfunction, decreased ovarian reserve, or some uterine factors would not be affected after discontinuation of pregnancy use and need to be investigated when a woman cannot get pregnant once she stopped contraceptive. So she might expect a delay of 3 months to 6 months with oral contraceptive, 3 to 4 months with IUD, and 10 months with the depomedroxyprogesterone acetate. And more research, of course, is needed for the hormonal implant and the vaginal ring and the transdermal patch, but because about them, as I said, we do not have enough data. The one thing I want to show you, it's true that we are here to talk about pregnancy, but you know that the non-usage of contraception leads to abortion, and abortion lead to many problems resulting in the end with ART. So I just want to show you why contraceptions are very important.
Condoms. Fun, sex.
Okay, thank you. We still have a road to do, but I think we're on the right way. Thank you.
Thank you, sir, for an excellent presentation.